Not yet, at least. Guys, please make sure I'm recording. Especially on days like today. I need to check, where am I at in my cycle? Because I swear to God, this is not a fun time. Okay, anyways, the Rome method is on that paper also. I know a couple of you use that method. That's the one you use, Lisa, right? Rome method? Yeah. Anyway, so step 1 is to complete the tic-tac-toe board. Step 2, determine your pH. Is it acidic, alkaline? Is it normal? Step 3 is your CO2 or bicarb, high or low. And then we interpret our ABG. Is it respiratory or metabolic? Is it acidosis or alkalosis? Okay. So, this should be very, very much a review. Okay, so I really hope you carried what we learned last term over into this term, and then we can just add to it. All right, so respiratory acidosis, this is when our CO2 is high. Remember, acid equals CO2. What is another thing that is equal to acid?
High.
Yes.
Hold on, I gotta forget the word.
No.
No. High.
Yes. Hydrogen.
Hydrogen.
Hydrogen ions. Okay. Acid equals carbon dioxide, also equals hydrogen ions. Because remember, your kidneys can't get rid of CO2. That's only for your lungs to get rid of.
Okay, so acid equals what?
Acid equals CO2,
CO2.
also equals hydrogen ions. Because remember, your lungs are the only thing that can get rid of CO2. If your kidneys want to compensate for acidosis, the only thing it can let go of is excess hydrogen ions. Okay, so that is the kidney's way of trying to get rid of acid. All right, so don't forget that all three of those are the same thing. Okay, so acidosis occurs when your CO2 is above 45 and your pH is below 7.35. So your cause is anything that causes respiratory depression. Remember, this is your patient with COPD that's holding on to their carbon dioxide. This is your patient that has had a drug overdose, okay? Whether it is accidental or it happens in the hospital or it happens on the side of the road, it's all the same thing no matter how it happens. Respirations become very, very low and shallow, right? Which means that they're not bringing in a lot of oxygen, but they're also inhaling enough CO2. So, and that adds to the retention of CO2, which increases our acid, okay? When we increase our CO2, we then start becoming symptomatic of CO2 retention, which is called hypercapnia. Remember, hypercapnia is the retention of CO2. Okay? So then our patients become anxious. They become confused, lethargic, agitated. All of a sudden, I don't know why the first thing that came to my head was Norris. I don't even know a Norris. But Miss Norris is all of a sudden having a COP exacerbation, and she is a nice old lady, and the next thing you know, she's telling you to go blank yourself because she's agitated and she's retaining CO2 and she's hypercapnic. Okay? So, causes respiratory depression, drugs, opiates, sedatives, anesthesia, increased intracranial pressure, sleep apnea, anything that causes impaired gas exchange, which is then our COPD, pneumonia, chest wall trauma, PEs, pulmonary embolisms. Okay, so symptoms, altered level of consciousness, we have a decreased blood pressure eventually, a decreased respiratory rate, hypoxia, and then dysrhythmias. Okay, this decreased blood pressure and dysrhythmias are going to be later stages. Okay. And this little guy says to compensate for acidosis, hydrogen ions can lessen. Hydrogen ions move into the cells to lower the pH, causing the potassium to leave the cells and enter the blood. This causes hyperkalemia. So an increase in hydrogen ions is going to cause an increase in potassium because the potassium is trying to compensate by having an exchange. So remember, it's kind of like insulin and potassium. No, that's a lie. Erase what I just said. That would cause hypo. That's a lie. So when you have an increase in hydrogen ions, you're going to see an increase in serum potassium, which is going to put us at risk for dysrhythmias, arrhythmias, and cardiac arrest. Okay. So our treatment is going to be administering oxygen, suction, secretions, turn, cough, deep breathe, and antibiotics if needed. But it's not just administering oxygen, right? Because administering oxygen is only helping in inspiration. What do we need to happen if we're retaining CO2? We need exhalation, expiration. So it's not just about administering oxygen. It's also about facilitating exhaling, okay? Which is where our BiPAP and CPAP come into play. And then also mechanical ventilation with a ventilator, because we can control and we can force the patient to exhale, correcting their CO2, okay? So exhaling allows CO2 to be released. So think anything that weakens this response will cause an increased CO2.
Before you move on,
Yeah.
You said late symptoms of the dysrhythmias and hypoxia. Do you want us to know early and late, or just
Not really. I just want you, she's asking if I want you to know early signs versus late signs, which is a great question. And it's not that I want you to know that, it's just that I want you to understand the pathophysiology. Because when you think about this, thing that's going to happen, your heart rate is going to go up. Right? Your respiratory rate is going to try to go up. Okay? Your blood pressure is going to go up because what is your body trying to do? It's trying to compensate. It's trying to oxygenate. And the only way it can oxygenate is if it pumps more blood faster and if you breathe faster. Well, guess what you can't do if you have a drug overdose? Or you're too sedated. Your opiates are too strong. Your sedatives, your anesthesia is too high. And you're not being supported with ventilation.
You're not going to let off the CO2.
You can't let off the CO2, but you don't have that response to do it on your own. Right? Because if you hold your breath, eventually your brain's going to force you to breathe. Remember when we talked about drowning?
Oh, yeah.
And that spontaneous inhalation of water, that happens because your brain is forcing you to breathe, right? But when you're depressed by drugs, that respiratory center in your brain that's saying, hey, I need you to breathe faster, I need more oxygen, it's not responding. It's not working because it's depressed, okay? So you're not able to let it off. That normal response isn't able to occur. So when you get to a point where you see a decreased blood pressure, and then even when you get to a point with bradycardia, your patient's about to code because you're in respiratory arrest. You're about to respiratory arrest. Okay.
Thank you.
So on the flip side, respiratory alkalosis, I want you to remember that hyperventilation. And what happens when we hyperventilate, with that feeling in your body? You get all lightheaded. You get all dizzy and tremory, right? You're like, and you can't even control it. You can't even stop it, right? So that's in very large amount of oxygenation and you're blowing off all of your CO2 by this rapid breathing. Okay? So anything that can cause hyperventilation, which can include anxiety, pain, fever, asthma, PE. I want you to make a special little note actually next to asthma, because that can really go either way. Okay? When we're talking about alkalosis versus acidosis, because what is COPD characterized as? It's a restrictive pulmonary disease. So is asthma. Asthma is a restrictive pulmonary disease. So a lot of the times when we're specifically talking about asthma, we actually have CO2 retention in the bases of the lungs because that wheezing and bronchoconstriction doesn't allow the patient to exhale their CO2. So you can see alkalosis and acidosis with asthma. Okay. PE, aspirin toxicity, and mechanical overventilation. So this is when your CO2 is less than 35, your pH is greater than 7.45. You have an increased respiratory rate and depth. It's these big, large breaths that are happening rapidly. An increased heart rate, because what happens when you're anxious? You're tachycardic. When you're in pain, you're tachycardic. First sign of a fever and sepsis, tachycardia. Okay. Confusion occurs because of the increase in oxygenation and the alkalosis too. So you have confusion on both sides. Okay. And then the dysrhythmias occur the opposite way, because to compensate for alkalosis, this should say alkalosis, the hydrogen ions move out of the cells to increase the pH, causing potassium to enter the cells and leave you hypokalemic. So it's saying, hey, I think you need acid, so I'm gonna give you my hydrogen ions that I'm holding on to inside of my cell, and I'm gonna put it out into your serum to try to help you, to try to compensate for you. So in exchange, that potassium goes inside, okay, causing hypokalemia. So your treatment is going to be breathing techniques to slow down the breathing. And it's not really about slowing down the breathing. It's about retaining the CO2. It's about rebreathing the CO2, which is going to naturally slow down that respiratory rate because your body is returning to a normal place. Okay. So we can breathe into a paper bag, but who carries a paper bag? Not me. What do I have? I have my hands. I'm going to breathe into my cupped hands. Okay. Supplemental oxygen if needed. A lot of the times with alkalosis or respiratory alkalosis, you don't need extra oxygenation. This is really only if needed, okay? Anti-anxiety medications and then analgesics for pain. Also antipyretics for your fever, okay? Oh, well, at least it changed at the right time. All right. Metabolic acidosis. So this is when our bicarb is below 22. Our pH is below 7.35. And our cause is anything that causes acid production. So malnutrition, remember, when you have ketones, remember, it's called ketoacidosis. When you have a production of ketones, ketones equals acid. So you can add that to your equal list when we're talking about acids, right? So acid equals hydrogen ions equals carbon dioxide equals ketones. They're all the same thing. They're not all the same thing, obviously. They all produce acid. Okay? So when you see any of these in excess, you're going to see acidosis as a result.
Can you say that?
What?
Can you say?
That again? Yeah. So ketoacidosis, it says acid in the name. So acid, whenever you have an increase in hydrogen ions, ketone production, or carbon dioxide, you're going to see an increase in acidosis, in the acidity of your pH. Well, an increase in acidity. Okay. So really this malnutrition and DKA should really kind of just be lumped together, right? Because they're both producing those ketones, they're both producing those acids from the ketones. Sepsis, what we find in sepsis is an increase in lactic acid. Lactic acid occurs from muscle breakdown, and our bodies can't get rid of it. The higher your lactic is, the sicker you are. So a lot of the time, when a patient is admitted and they are in sepsis, they're really, really sick. One of our first labs that we're going to run is a lactic. Okay. And it's because it shows the level of muscle breakdown, shows that level of acidity and how sick our patient is or going to be. And then when our lactic starts trending down, our patient is getting better. Our acidosis is resolving. Okay. So remember when we were talking about DKA, we were talking about the anion gap, and when that gap closes, our patient's acidosis is getting better. Think about it the same way when we're thinking about lactic acidosis. When that gets lower, more into a normal range, your patient is getting better, their acidosis is resolving. Okay. And then you also see this in alcoholism.
Bless your acid.
No, acidosis. Metabolic acidosis you see in alcoholism. Because your liver is responsible for a lot of things. And when you have a lot of injury to the liver, you have a lot of buildup of acid, and that metabolism isn't blessed. Also, anything that causes a decrease in acid excretion. So if we are in acute or chronic kidney failure, that is going to reduce the amount of hydrogen ions that are released by the kidneys. And you're also holding on to your bicarb because your kidneys aren't functioning correctly. So the kidneys unable to excrete the waste causes a buildup of hydrogen ions, your acid, and a decreased bicarb release or reabsorption. Because remember, our kidneys compensate for acidosis by releasing hydrogen ions and retaining bicarb. So if it can't do that, our acidosis will get worse. And then anything that causes excessive bicarb loss, which includes severe diarrhea. So remember, bicarb comes out of your base. That's funny. Okay. So if you're pooping out all of your bicarb, you're going to be acidic. So on the flip side, if you're excessively vomiting, you're vomiting up all of your hydrochloric acid in your stomach, leading to alkalosis, right? So put diarrhea on the acidosis side because you're pooping out all your bicarb. So it's going to be the opposite. Vomiting is alkalosis, diarrhea is acidosis. Okay. Symptoms are going to include those Kussmaul respirations. Those are those irregular, deep, shallow, weird breaths that you see in DKA. And it's caused by the ketones. It's caused by that acid buildup. Okay. And it's actually not caused by the ketones. It's caused by the acidity itself because it's trying to blow off. Your lungs are trying to compensate by getting rid of the CO2. Okay. A decreased blood pressure, confusion, hypoxia, and hyperkalemia, which we already discussed, which is caused by the hydrogen ion shift. Okay. So when there's too many hydrogen ions in the blood serum, it's going to go in the cell. And as a result, the potassium that was intracellular goes out, causing hyperkalemia. Okay. Your treatment is electrolyte correction, initiate seizure precautions, and monitor respiratory status. Metabolic alkalosis, our bicarb is high, our pH is high. It's caused by anything that causes an excessive loss of acid, which includes vomiting, excessive GI suctioning, anything that causes excess bicarb. So, excessive bicarbonate administration. We can give bicarb. Okay. Excessive consumption of alkaline content, which includes antacids, milk, baking soda. Hyperaldosteronism. This causes sodium hydrogen exchange in the kidneys. So the hydrogen goes down, causing the bicarb to go up. And loop diuretics, which causes the kidneys to release hydrogen through the urine. The hydrogen goes down, causing the bicarb to go up. So your symptoms include a decreased respiratory rate because it wants to hold on to CO2. It wants to compensate by holding as much CO2 as it can. So instead of this rapid breathing, which causes it, we're going to do the opposite, try to slow it down. Hypoventilation. Okay. Hypokalemia, which we already talked about with the hydrogen ions. We don't have hydrogen ions. So our cell says, hey, I'm going to give you some. So it releases the hydrogen ions into the serum, causing the potassium to shift inside the cell, which is causing serum hypokalemia. Okay. This is going to result in lethargy, irritability, tetany, and Schaffstex. Now, this is more really, this Schaffstex has to do with what? Calcium and magnesium. So why is it a sign of alkalosis?
Hold on.
Yeah, just make sure, right? Because you know I don't like saying things that are wrong. What's the question?
What does
Why it shops that same hypokalemia?
Because the potassium.
No, because Schaffstex is a sign of
Calcium.
hypo and
That's what I
hypercalcemia,
just said. Count.
right?
But I'm on.
So I want to make sure we're not relating it to the potassium. I don't want you to think, oh, well, wait a second, I thought that was calcium, because it is. It is calcium. So alkalosis causes tetany by increasing the binding of serum calcium to albumin, which reduces the concentration of free calcium. The decrease in ionized calcium increases neuromuscular excitability, leading to symptoms like carpopedal spasms, paresthesia, muscle cramps. Both respiratory and metabolic alkalosis can trigger these spasms. So that is why when you're hyperventilating, you have those weird feelings of muscle spasms and that tingly in your arms and your fingers.
So it's basically blocking calcium
It's,
or making calcium more available.
yes, no, it's binding to the calcium. So yes, in a way it's blocking it,
Yeah.
causing
Okay,
a
that's what I'm trying to figure.
kind of like a faux hypocalcemia because it's binding to it. Okay?
So potassium is binding to the calcium,
No,
the ion.
The calcium, so it doesn't say that up there. It only says it on my Google because I Googled it because I don't like saying wrong things. The hypokalemia is being caused by the hydrogen ions.
Okay.
So don't look at this. Look at me.
I am.
Okay. So when you are in an alkalotic state, you don't have a lot of hydrogen or a lot of acid, right?
Right.
So your cell says, I want to help you, and I'm going to give you some of my acid that's in here, that's inside my cell.
Right.
So when that happens, the acid goes out, and that causes the potassium that's in the serum to go in, with
Okay.
causing hypokalemia. But that's not responsible for Schaff's, right? Schaff's is caused by hypocalcemia. And the hypocalcemia occurs because the calcium and albumin bind together. It's very sciencey.
Very good. Okay.
No, I just want you to know that that's why that feeling is occurring in your body.
Or why you may get these symptoms.
Why you're getting those symptoms, right? Because I expect you to know the symptoms of alkalosis. I expect you to know that paresthesia, that tingly feeling, the Schaff's, the irritability. But why is it happening? Is a really good to know. Okay. Your treatment is going to include antiemetics because we need to stop you from vomiting up all of your acid. Electrolyte replacement, IV fluids, and Diamox. Diamox is a through urination. So we said over here that loop diuretics like furosemide and bumetidine cause the loss of acid, and bicarb goes up. So Diamox is actually working by promoting the loss of bicarb to compensate. Okay. And apparently now we have a break.
Is that the only diuretic that does that causes loss of bicarb?
That's a good question.
Like shivering. Like
Your slides are
Yeah,
still skipping too.
Yep, it's just going.
I really, truly, am so annoyed with this.
Something's touching something.
So Diamox is primarily known for causing bicarbonate loss, leading to metabolic acidosis. Other diuretics typically cause metabolic alkalosis. So the answer is yes. Yeah, Diamox is really the only one that causes bicarb loss. So we're here until 3:30 today. 3:30?
Yeah,
3:30, right?
yeah.
Yeah. So I mean we have a lot of content. Huh?
man.
We have a lot of content to get through, and we don't have class on Monday, next Monday. So we have class today, we have class Wednesday. We don't have class on Monday
Is that our, oh, this is gonna be 19 Martin Luther King.
because it's Martin Luther King Day. And guy, let me just tell you, I love him. I love what he did, but he really screwed me this month. Just saying. Okay. He really screwed up my schedule this month. So 10 minutes, no more, and we'll come right back.
I want to cross that bridge.
All right, ready?
That was the most funniest thing I ever did. You brought COVID here. I was like, I'm born in this.
Not the doctor.
All right.
That's so funny. Not to get reported.
That's not.
That's
Just grown ass man. I will be.
What did I do? Ready?
Yes.
Ready? What's wrong?
It's very cool. I'm ready.
I already gave away both of my heated blankets.
Stop, not too long.
All right. So this is acute respiratory distress syndrome, aka ARDS. Excuse me. ARDS has been around for a really long time, forever. But we saw a huge, devastating increase in ARDS when COVID hit. Truly, we saw in the ICU cases of ARDS, severe ARDS, maybe 5 times a year. Total, in a level 1 trauma center with 3 ICUs, we saw ARDS maybe 5 times a year. And then when COVID hit, we had 29 beds full at the same time of every single 29 of those patients dying from ARDS. Multiple times.
So is this a state?
Yes.
Okay.
This is a syndrome. This is something that occurs, and we will get into all of its characteristics. So, ARDS, and I'm not going to say the whole thing. You're going to hear me refer to it as ARDS from now on. ARDS is a life-threatening lung disease that causes severe damage to the alveoli due to inflammation and pulmonary edema. It is not a primary lung disease. It is caused by something else. So it happens secondary to the primary disease. Whether that primary disease is COVID, whether the primary disease is the flu, which is where we saw it most of the time in adults. If we're talking pediatrics, probably like RSV would do this in severe cases with kids. What were you going to say? This?
Oh, no, you'd already said it. I was like, okay, if it came from something, that's why you see so much of it with COVID.
Yes,
Because
COVID was the
primary.
primary. Yeah,
Okay.
exactly. So it is a complication from a systemic injury that causes widespread inflammation and causes damage to the lungs. That damage can, and most of the time, causes permanent damage. So when you see those patients that tell you they have long COVID and they have respiratory symptoms that never left, that's because they had permanent damage occur from ARDS and they survived.
I had a patient like this a couple weeks ago.
Yeah.
She got it from aspiration pneumonia.
She got ARDS from aspiration pneumonia?
Yeah, tube feed was backing up into her lungs from like a peg tube malfunction.
Yeah. So
She died.
It's not that doesn't surprise me. It's not always caused by a virus like the flu or COVID. It can be caused by bacterial pneumonia that is occurring because of aspiration. So the causes, you have indirect, which is the injury outside of the lungs. So this is where you see ARDS occurring from sepsis. Severe, and we're talking about the most severe cases. Okay. So severe sepsis, pancreatitis, drug overdose, burns, and we're going to get into burns next week. And then direct injury is aspiration, chest trauma, drowning. Guess what? There's a lot of bacteria in water, and it's not supposed to go in your lungs. An inhalation injury that can happen from chemicals, it can happen from water, it can happen from a lot of things. So the pathophysiology is that the infection or injury causes severe inflammation within the lung tissue. That inflammation causes severe fluid buildup. And that fluid then leaks into the capillaries and alveoli. Or I'm sorry, the fluid in nearby capillaries leak into the alveolar space. And remember, what do alveoli not do underwater?
Exchange, yeah.
They don't exchange nothing. Okay? It is a diffusion. We're not talking about osmosis. Okay? Diffusion is particles moving across an airspace. Osmosis is when things move across water. And our alveoli, they don't do osmosis. Okay? So the alveoli become filled with fluid. The body stops producing surfactant. You should recognize this word from OB.
That's what keeps the lungs open.
Surfactant is what keeps the alveoli from collapsing,
Oh, okay.
which
Well,
is why it's so important for babies because they don't produce.
But doesn't that keep the lungs open?
Yes.
Okay.
Well, so alveoli collapse is going to collapse the lung because there's no air exchange. So yeah, same idea. But surfactant is necessary for all of us to be able to keep our alveoli open. Okay. So without the surfactant, it would cause the alveoli to collapse. And then this causes impaired gas exchange, and then the lungs become stiff and non-compliant because they become fibrous. Okay. So this next slide shows you the stages. So your diagnostics, you're going to have a chest x-ray that's completely whited out. I mean, it is full of fluid. Your gases are trash. Your patient's is most likely going to be severely acidotic. Okay. You have probably, if it's from sepsis, you may have positive blood cultures. And then you could have bronchoscopy if you wanted to get like a culture from inside of the lungs. So your ARDS stages, which you should know, exudative occurs 4 to 7 days after the injury. So when this happens, you have damage to the capillary membrane, and this leads to that fluid leaking into the alveolar space. The decreased surfactant leads to atelectasis, which is the collapse of the alveoli. Hyaline membrane, which is a fibrous membrane, starts to develop and leads to decreased lung elasticity. The way that our lungs function is to be able to fully expand and then fully collapse. Fibrous tissue impedes inhalation and exhalation. Okay? I need you to know this word. Well, 2 words. Refractory hypoxemia is a very important term that I need you to know. This is when low blood oxygen levels continue to occur even though your patient is maxed on oxygen. They are on 100% FiO2 on mechanical ventilation, and their SpO2 is garbage. 80s, 70s, 60s, 50s. There is no oxygenation occurring. There is no carbon dioxide and oxygen exchange.
What do you do then?
Exactly. What do you do?
Start praying.
Amen.
So would this be one of the things that would qualify a patient to go on ECMO?
Yes.
Okay.
She asked if this was a qualifying thing for someone to try ECMO. The answer would be yes.
Mm.
So,
Scary.
refractory hypoxemia. This occurs. And when you supplement oxygen to anyone, you are going to anticipate an increase in their SpO2, correct?
Correct.
So, when there is no response or very little response to oxygenation, you can see refractory hypoxemia in a lot of things. So say I have a patient on a non-rebreather on 15 liters max flow, and my patient is still a saturation in the 70s. That is refractory hypoxemia. They are requiring more oxygen than their blood can carry. And the alveoli and capillary beds can exchange. It gets to a severe point when your patient is maxed out at 100% FiO2 on the vent. And then you are seeing an SpO2 in the 70s, 50s. That is severe refractory hypoxemia. So I need you to know what that means, that word. I need you to know those two words, okay? Your shortness of breath is your earliest sign of this exudative phase. For the proliferative phase, this occurs 7 to 21 days after injury. This is the initiation of lung repair and resorption of edema. This is when your body is like, okay, enough is enough. Let's start trying to repair ourselves, okay? Some patients, we see them recover. This is the point during COVID where our patients started either taking a turn for the better or taking a left turn for the way worse. And it was really right at that like 14 to 21 day mark on the bed. I mean, I know it says 7 to 21, but I'm just saying in that experience. I hope you guys never have to experience another COVID in your career. So patients that do not recover, the lung tissue continues to become more dense and fibrous. The more dense and fibrous tissue, the more decrease in lung elasticity, the less ventilation, inhalation, and exhalation you have. And this is called decreased lung compliance. So this is when the lungs continue to become stiff, and that worsens your hypoxemia. So decreased lung compliance, they're not listening. Remember, compliance is when someone does what you tell them to do. The lungs have one job. It's to breathe. If they can't breathe adequately because they're injured, because they're full of fibrous tissue, you have decreased lung compliance. Okay? And then our last stage is fibrotic. This occurs after 3 weeks of injury. You have extensive lung scarring that's present within the lungs. The lungs are hard and stiff. They're extremely fibrous. They do not want to move. The alveoli lose the infrastructure, which worsens the gas exchange, lung compliance, and hypoxemia. If your patient gets to this point, your mortality rate is extremely high. And they probably will not survive. So this patient is ventilator dependent. First of all, this patient's been ventilator dependent for a hot minute before this stage, okay? But at this point, this is where you see that severe refractory hypoxemia. There's nothing you can do to oxygenate this patient. At this point, these patients were prone on their stomach, paralyzed with a paralytic, sedated, and completely dependent on ventilation, and still dying at this point.
That's terrible. Because they're sedated and in a coma. Like, how you dying? You just
Like,
suffocate.
So at this point, you are literally, the patient has we take away all control. We have all the control.
I know, and I think that's why I'm so baffled, because
It's horrible.
if you're intubated, that means the machine it's already set how much oxygen you're gonna get, how much it's gonna breathe for you. You're in a coma, so there's no metabolic use because you're not doing anything.
Well, you have to remember too that there's different levels of ventilation, right?
Right?
And we're going to learn about those. So, but this is complete dependence.
No,
There is nothing.
and I guess that's why I just mind body.
It is. It's absolutely mind-boggling. It's heartbreaking and soul-crushing and horrible to watch. It's horrible to watch one patient go through it, let alone 29, all at the same time.
Yeah. Terrible.
Yeah.
It's,
Any questions on the stages of arts?
yeah, can you give me a second to write this?
Yeah.
Do you want us to know, or like, do you want us, I know you said you want us to know these.
I want you to know this box,
These time frames, 4 to
The
7,
whole box.
7 to 12.
a whole box. I want you to know the whole box. I'm curious, hearing this the second time around, does it still feel, I don't know.
Foreign. Like a refresher.
Good. I don't mean to,
Sense, but.
I don't mean to put your stuff out.
No, it's okay.
Well, even like, but I mean, I'm sure you guys have heard, I mean, Rashonda literally missed it by points.
So she just.
Like she was so close.
Had baby breath.
She was so close.
Yeah, so that was.
Everything. That turn you might be. All right, I'm done.
So treatment for ARDS. We have, remember, ARDS is the secondary. It is not the primary. So when you think about the treatment for ARDS, you have to think about, you have to treat the primary, the underlying cause. Because after that, excuse me, it's all symptomatic management at that point. But if you don't fix the first part of the problem, you have no hope of ever coming back. So if your patient has an infection, we need antibiotics. Corticosteroids are not only going to decrease the inflammatory response, but they're going to help with oxygenation, right? Diuretics, we're trying to get off all of that pulmonary edema. That's why all of this is happening, because of the severe inflammation and pulmonary edema within the lungs. And inhaled vasodilators. So you can, so this can also be your albuterol, because albuterol is going to bronchodilate. It also works on beta 1, beta 2. So it also vasodilates. When we talk about oxygenation, in the early stages, you're going to start off just like everybody else. You're going to start with a nasal cannula. You're going to then see hypoxia, and you're going to move to a non-rebreather. And then when your patient is still not oxygenating and getting worse, you're going to have them self-prone in the bed, right? You're going to say, hey, Mr. Jones, I need you to lay on your stomach for a couple hours, see if it helps your oxygenation. And then that's going to fail. And then you're going to say, okay, we're going to try the BiPAP. BiPAP is bi-level, so two levels. Bi-level positive airway pressure. Write that down. Bi-level positive airway pressure. Bi-level, I mean that as in inhaling and exhaling. Remember, we talked about I can force you to exhale. My BiPAP forces you to exhale because it's bi-level. Okay. So BiPAP is taking a little tiny bit of control over the respiratory status. We can increase the FiO2 on a BiPAP, so we can supply a high amount of oxygen. But guess what is really hard to be compliant with? A BiPAP. Have you ever seen a BiPAP?
Mhm.
Have you ever taken one off while it's still on? And you take it off and it's like, the air is so forceful. Okay. What also do we sometimes completely forget about? Our skin integrity.
Oh.
Your patient's bridge of their nose is gone.
Mhm.
There's so much pressure from that BiPAP on their face, especially in this situation, because it's strapped so tightly, because you can't have leaks. It has to be seamless. There's so much pressure on the face that then you're worrying about necrosis of the tissues. Okay?
I never seen one of these before.
A BiPAP?
Yeah.
Are you looking it up?
Yeah.
Look, type in bypass mask.
BiPAP mask.
When I had COVID, I had COVID back in August of 2020. I had gotten exposed at work, and 3 days I started to DSAT. 4 days in, I was intubated, and when I was extubated, they had still put me on BiPAP to see how. They put me on CPAP and I failed the breathing trials, and they put me on BiPAP because I still wasn't adequately breathing, but I was trying to breathe on my own. And my nurse patted my face, like the bridge of my nose, under my eyes, my cheeks, but like my forehead from where the strap was at. And then like I actually had bald spots in my, like the crown of my hair from where the straps were like ripping out my hair.
A very good story. Okay, so Brittany had COVID back in 2020. 2020, right?
Yeah.
I'm assuming because it was severe. So she was admitted nasal cannula. She continued to desat as they increased her oxygenation. She ended up intubated. She was just talking about she had a strip on her forehead and she had pressure injuries on her forehead from the strip. The strip that she's talking about, that is a very special strip that connects to your paralytic. So that means that Brittany was in a severe respiratory state. And it's so severe that they had to use a paralytic to completely paralyze every muscle in her body so that they could control her lung compliance and oxygenation. And that strip on her forehead, it's called, it allows us to make sure that you are adequately paralyzed. Okay? It comes with its own rhythm strip. All right? So then when she was extubated, she failed CPAP 3 times because she failed her spontaneous breathing trial and failed on CPAP, which is horrifying and so scary. And I can't imagine how you felt in that moment. It probably just feels like a nightmare at this point.
Mhm.
And then she was placed on BiPAP. She said that her nurse literally had padding all around her face, all around her forehead. Every single part of her face was padded. We padded every single inch of everybody. It was insane. Okay. So, how long were you on BiPAP? First of all,
So
were you intubated?
I
And
was
where-
intubated for 11 days. So I have a history of like respiratory issues to begin. So I was already a crippling and like asthmatic. So when I had heard that I was exposed to COVID, I freaked out, called my boss, and I was like, hey, things got to start happening now because like I'm terrified of what's going to happen. I called my mom and I said, Mom, I feel like I'm going to pass out. And she had logged into my home cameras and she actually watched me faint and called 911. So I was intubated for 11 days.
Where?
St. Joe's and
Okay.
Warren. So I was intubated for
How
11
old
days.
are you?
26. No, 25. I
had
hadn't
one
even turned 26 yet.
We only had one patient in her 20s. She was 24. She was our first ECMO. And she survived. Her mother was also intubated down the hallway, and her mother survived. And we got to reunite them, and it was very beautiful. Go ahead, Brittany.
Aw. So once I was extubated, I had originally passed my spontaneous breathing trial, which is what allowed them to extubate me.
We're
And
gonna
then I
talk about
started having
breathing trials a lot.
increased shortness of breath, and I was experiencing like severe chest pain, but it wasn't like chest pain as much as it was like it felt like my ribs were being crushed.
Yeah.
Then we did the chest x-ray and they determined that I had COVID pneumonia, and we went from there. And that's when they were like, okay, we're going to try CPAP because you're still wanting to breathe on your own. And I had already denied reintubation at this time. I was like, we are not doing that again. The CPAP didn't work, so they were like, okay, we have to go to BiPAP and we don't want to intubate you, so these are the options. And I looked at my mom and I told her she needed to decide what to do with me, because if I wasn't
So-
making it out of this, I wasn't doing it again.
So that must have been later and not as early in COVID, because when COVID first hit, we didn't use BiPAPs because you needed a very special filter that was never made. Nobody ever made it because we were under the assumption that COVID was airborne. We didn't know what was going to happen. So if we were under the impression that if we used a BiPAP, it was just going to spray airborne particles in the air, which is why you can't use BiPAPs for TB patients. It's the same reason, because TB is airborne, right? So you must have gotten COVID at least 6 months to a year after it first started.
It was
Because-
August of 2020. August 21st of 2020.
So March, April, May, June, July, August, 6 months. Yeah. And then they made these special filters for our BiPAPs for us to be able to use them and not put everyone in the room at risk. Because at that point, even 6 months in, we still didn't know what to do. We were literally just throwing stuff at the wall to see if it would stick. Literally. So obviously BiPAP was successful.
Mhm.
Did they ever put you on a heated high flow with the little nasal pillow pads and the big
The
tubing?
Airvo.
Yeah.
I was on an Airvo. When I went home on high flow oxygen. And then I worked very, very hard with respiratory therapy, physical therapy, and occupational therapy so that I'm no longer oxygen dependent. But it took about a year before I was finally able to like live normally. And it was the worst year of my life.
26 years old.
Yeah, that's what I'm saying. She's
Like-
so young.
So young. And you have to remember too, she already told us she was a severe asthmatic. So this didn't just happen to 20-year-olds. We didn't see this happening to our younger population, but it was because she was already so severely compromised because of her severe asthma.
Yeah, I'm glad she's okay.
You bring your girl.
Do you hear them?
I did not.
They said they're glad you're alive and thank God you're here. And shout out to you.
I give all of the credit to my ICU nurses, my intensivists, and my internal med doctor, because honestly, without them, there was no chance in making it.
And I mean, to be frank, you are correct. I mean, if you would have been left with a team that didn't understand, or this happened right at the beginning where we really didn't know anything about what we were doing, that absolutely could have compromised your possibility of surviving. So you're very, very, very lucky, and I'm glad that you're still here. So when we talk about oxygenation, we have a BiPAP in early stages. And before COVID, remember, this can happen from sepsis. This happened from the flu a couple times a year. This happened from other situations. So we had no issue using BiPAP on those other situations because those other situations weren't airborne. The only time the BiPAP got questioned was when we thought COVID was airborne. Okay. So then we have.
So can we use it for TB now that they have those filters? Did you say they have a special filter for it now?
Kelsey, that's a great question. I honestly don't know. I don't know. I would have to look that up. I haven't. Yeah, I don't know. So we have mechanical ventilation, prone positioning, which is very helpful. So if you think about the structure of the lungs, like if you picture them in your textbook, right? You have the surface area that's on the front. And then if you think about the lungs from the posterior side, you have way more surface area on the posterior side of your lungs. Okay. So, and also fluid moves. So when you position your patient prone, that not only does it move the fluid to a different place, allowing that outline that has been so damaged to hopefully heal and maybe have some oxygenation in the posterior and in the bases. It also allows for greater lung compliance because there's a lot more space to expand when you're in a prone position versus supine. That's why prone works so well. And then we have ECMO. ECMO is, I hate ECMO. I hate ECMO. I hate it so much. And it's because, not because it's not one of the most beautiful things I've ever seen, witnessed, because it's truly life-saving. But ECMO is so scary because I want you to imagine a garden hose, and I'm not exaggerating. I'm literally not exaggerating. A garden hose coming out of your jugular vein and another garden hose coming out, I want to say arterially, but I'm not 100% on that. It has to be. And one has to be venous and one has to be arterial. And your blood is taken out of your body, oxygenated through a machine, and then returned to your body. So your lungs literally are not breathing. They are not functioning whatsoever. And the idea is that it gives the lungs so much rest that they're able to heal while they're not being used. That's the idea.
That's so scary.
The thing is, when you have a couple ARDS cases a year, and if somebody is a candidate for ECMO, because not everyone is a candidate for ECMO, you have to be on really intense anticoagulation. Because if you're running your blood through a machine to oxygenate, it cannot clot. You are dependent on this machine. So not everyone is a candidate for ECMO. So if you're lucky enough to be a candidate for ECMO, then you have to have a very special physician, a perfusionist, to come in and run that machine. There's not a lot of those in the
I
world.
was just gonna ask you, so ECMO is like bypass?
ECMO is kind of like bypass for the lungs.
Okay.
Bypass is for the heart, and ECMO, is bypass for the lungs. Yeah. So we had all of these patients that it's like, well, what about ECMO? What about ECMO? We could use ECMO. You think we were low on ventilators during COVID? We were severely low on ECMO supplies. People that were able to run ECMO, place ECMO. ECMO became a dream during COVID.
So the blood's still going through the lung because that's the way system is just not doing them.
Correct. The blood is still going through its own circulatory pathway.
Okay.
Yes. That pathway is never going to be interrupted. It's just getting oxygenated outside of the body, not within the lung tissue. Okay. So nursing interventions most likely requiring ICU care. We have close monitoring, vital signs, and breathing pattern. ABGs, a lot of them. Labs, a lot of them. These patients have art lines. They have triple lumens. They have easy access to get blood and give all the medications your little heart desires. Strict I's and O's. Supportive care in Q2 turning, especially when your patient is intubated, sedated, and paralyzed, because they can't offload anything. Okay. Tube feeds started early because what do we need to heal? But great proteins. Our body needs essential amino acids. Amino acids are proteins. Without those amino acids, our bodies cannot function correctly. They cannot heal properly. So it's not really all about the nutrition and the calories. It's truly about the protein and the energy intake, because think about when you're sick and the high metabolic rate that you have when you have a fever, and then times that by 1,000,000 with ARDS. Your body is requiring an insane amount of metabolic energy and also an insane amount of oxygen demand for that metabolic energy, and it doesn't have it. Emma said there's a video out there with a care team that was able to transport their ECMO patient outside and shoot some basketballs. I couldn't imagine. Never in my wildest dreams would I ever want to be a part of such things. I think that is the most beautiful thing I've ever heard, Emma, but God, that would scare me to death. I'd go hide me in a closet while you do it. I don't want to see it. It's like when somebody throws a kid in the air and you're like, oh my God, are you going to catch him? No, never in 1,000,000 years. Nope, never. Also DVT prophylaxis, obviously, right? Your patient is immobile. They're ventilator dependent. You need to have DVT prophylaxis. And then hopefully at some point, ventilation. Okay. How are we doing so far? It's a lot. It's heavy. This is a heavy topic with a high mortality rate.
This is a little more interesting than heart. Yeah.
So we're doing okay. How are we doing online? You guys okay?
Yeah. When they're saying DVT prophylaxis, they're talking about that FME.
When we're talking about that's a good question. When we're talking about DVD prophylaxis, yes, absolutely SCDs, but we're also talking heparin, Lovenox injections. Most of your patients, if not all of your patients, especially in the ICU, they're all on either heparin or Lovenox. Okay, so at this point, we have concluded ARDS. Does anybody have any questions on ARDS before we move on to acute respiratory failure? Okay. Anybody have questions online before we move on? No? Okay. All right. So acute respiratory failure, this is sudden and life-threatening deterioration in gas exchange function in the lungs. So when oxygen and carbon dioxide cannot keep up with the exchange of oxygen and carbon dioxide during cell exchange, we're talking about that metabolic energy that is needed. Okay, so this happens acutely, suddenly. Your patient is sick. They are requiring a large amount of oxygen for their metabolic energy production, and they can't get it fast enough. And that lack of oxygenation and the demand, and not meeting the demand, causes that respiratory failure suddenly. So your patient becomes hypoxemic and hypercapnic. So not only do they have low oxygen saturation, they have high carbon dioxide. Okay. So your PaO2 is less than 50 on room air. And hypercapnia, your CO2 is greater than 50 and your pH is less than 7.35. So you're acidotic. Okay. So with acute respiratory failure, you're seeing both hypoxemia and hypercapnia. That is definitely a characteristic of acute respiratory failure. Okay. So you have early signs, you have progressive stages, and then you have final stages. In the early part of acute respiratory failure, you are restless. You're fatigued because of your hypoxemia, because your blood pressure is high, and you're tachycardic because your body is trying to oxygenate and it can't, because it can't get enough. You're short of breath because you can't get enough of it. And we already talked about your tachycardic, your tachypnic, your respiratory rate is high because we need more air. I need more oxygen. Okay. What happens, do you think, when we hit progressive? Because during early, that's hypoxemia. Progressive, what has now occurred? Hypercapnia. In our progressive stage, hypercapnia has now occurred. What do we see with hypercapnia? What do we see with respiratory acidosis? We see confusion. We see lethargic. We see tachycardia. Okay? Our patient is in distress. Central cyanosis. Core. Our core is cyanotic. Central. Right? This is our periphery, our arms and our legs, our toes and our fingers.
Just gonna be.
So think about periorbital or perioral cyanosis. The lips are blue. Periorbital cyanosis. The conjunctiva is pale. Right? You could have pale, borderline cyanosis within their core of their body.
So our early signs are hypoxia.
Our early signs are hypoxia.
Okay.
Our progressive signs is when hypoxia is occurring and hypercapnia is also occurring at the same time. Okay. So then when we get to our final stage, this is when our patient, that respiratory drive is gone. We have respiratory arrest, the breathing stops, which then leads to the heart stopping, which then obviously leads to death. So respiratory arrest is when we stop breathing and then the heart stops. Okay. So respiratory arresting and cardiac arresting are two very different things. Nursing interventions are going to include ICU level care, ABGs, that says POX, like pulse ox.
Yeah.
I sure hope so.
Vital signs, hygiene. This is important for all ICU patients, okay? It is standard to provide oral care to intubated patients every 4 hours. Range of motion exercises often, at least one time per shift. Q2 turns. Very good skincare. These patients are getting bathed. These patients are getting turned. They're getting lotioned. You ever want to see top-notch patient care? You go into an ICU and you spend the night there. And your patient is getting cleaned from top to bottom and lotioned and repositioned. Because remember, we don't have aides. We don't have techs in the ICU. Some ICUs are lucky enough to have them. Most of them, they don't have techs. We have us. We have nurses. And our patients are either 1-to-1s or they're 2-to-1. And we go together as a team and we go bathe our patient. We lotion them up. We Q2 turn every 2 hours. We're on it. Because we only have 2 of them. They're total care. Okay. Oxygenation therapy is to manage the mechanical ventilator. We don't do that. Okay. Nurses don't do that. That is not our job. Respiratory therapists are very, very, what's the word? Protective over their ventilators. You do not touch the ventilator. The only time a nurse touches a ventilator is when it gets disconnected by accident and you need to connect it back together, or you need to hit max O2, and give them 100% FiO2 if they need it. Okay. We don't change settings. No. Absolutely not. They don't even like it when the intensivist changes the settings. They're very protective. So if something happens with your oxygenation management with your ventilator, I couldn't tell you how many times I've called my respiratory therapist and been like, hey, it's making a noise and it's going do-do-do-do, do-do-do-do-do. And they're like, okay, I'll be right there. I'm not kidding. I literally have done that. Do we need to be educated about our ventilator and our ventilator settings and how it works and all the things? Absolutely. Do we touch it? No, we don't. Okay.
I learned
one of the alarms when her patient self-extubated. When it goes, one of the nurses on TikTok said it says, "Get your butt in here." And that's
We are going to talk about the alarm system on the ventilator, high pressure alarms, and what those mean, and when you can stay seated and when you need to run, because they're different. Okay. Emotional and psychosocial support. At this point, if your patient is intubated, a lot of this is happening between you and the family. Okay. But also, we talk to our intubated patients always. I want you to imagine being in this situation. Now, Brittany, I don't know if you have any memories of being intubated. I really hope that you don't. We try really hard to keep our patients sedated adequately. It's really important to us. But there is something called ICU delirium. And we're talking about really heavy hitting drugs, really heavy sedatives. Okay. And sometimes, especially during COVID, these patients were so hard to sedate because their tolerance to our drugs got so high that we were giving these patients ketamine. And ketamine is going to make you trip balls. Okay. These patients were in Alice in Wonderland in their brain. All right. And then we're talking about hypercapnia, which is causing even more confusion. And the human brain is a very, very special, crazy place. And it can take you on a wild ride. Okay. So listening to some patients recall their experiences in critical care is really scary. So imagine being tied to a bed because, by the way, every intubated patient is restrained at risk for self-extubation. Okay.
Was your guy not restrained?
Yeah, he was slouched down on the bed. So not only are you restrained to the bed, you also have a tube in your throat that's breathing for you. Okay. And then all of a sudden, you have somebody come into your room, rip the blankets off, bathe you, your naked body, in cold, hopefully not cold, soapy water, dry you off. They have another nurse with them. They're blah blahing about whatever they're talking about, okay, while they're flipping your body back and forth like you're a rag doll, repositioning your body, hopefully putting you in a comfortable position, and then turning the lights off and leaving. We don't know what they can hear. We never know what they can hear. So you walk into that room just like you walk into every single patient room that you've ever walked into. Hi, my name is Jessica. I'm going to be your nurse today, and I'm going to take care of you. I'm taking your vital signs right now. I'm going to get you turned. I'm going to get you cleaned up. I'm going to rub lotion on you. I'm going to try to get you more comfortable. I have to wipe your bottom. I have to clean your private area. Okay? Imagine you laying in a bed, sedated, with your arms strapped to your sides, and someone shoving a washcloth in between your legs and not telling you that that's what they're doing. Okay? Please talk to your intubated patients. It is so, so very important. Okay? So when we talk about emotional and psychosocial support, that's really what we're talking about when we're talking about the patient. But on the other side, we are the only person between the family and the patient. The doctor they don't take time to call. I mean, sometimes they do. It depends on the physician. To call the patient's family and have these long, in-depth conversations, right? You call the nurse and you ask for the nurse and you say, hey, how is so-and-so? I remember staying on the phone for like 20 minutes with family members, just talking. They call every day, they call every night because we weren't allowed to have visitors. Okay. So your treatment for acute respiratory failure is going to be very similar to ARDS, where you correct the underlying cause because you need to restore the gas exchange. At the end of the day, it's all about oxygenation. I've said that to you 100 times at this point. It all comes down to oxygenation. Okay. Supplemental oxygen, most likely, they may need mechanical ventilation. And then if your patient is in acute respiratory failure because of opiates, then obviously we need to reverse that. And we have Narcan or naloxone to reverse opioids. What is the drug that reverses benzos? Benzodiazepines.
Flumazenil.
Flumazenil. Yes, it is. You better know that.
I need to.
You better know that. Flumazenil. Fluman.
Bill.
Flumaz. No. Flumaz. Flumazinell. Flumazenil.
Thank you.
Maybe. I don't know. It might be wrong.
FLUMAZNI.
Thank you.
There you go. FLUMAZ. Ooh, Brittany spelled it for us.
There we go.
ENIN. Flumazenil is the reversal antidote for benzos. Okay, benzodiazepines.
I said I'm gonna have to Google this because this here, I didn't know where I'm what it is.
Okay, so I introduced you to this a teeny tiny bit last term. I gave you a piece of paper. I said you don't have to do this right now, but eventually you're going to have to do this. So I want you to look at it at least once. Okay, this is your PF ratio. The PF ratio tells the inspired oxygenation that the patient is receiving. This is how we determine if the patient needs more FiO2 or less. Okay. So this helps determine if the patient is getting enough oxygen from the supplemental oxygen on every breath in. So this is divided by your FiO2. And there on Brightspace is a thing under learning materials that is specifically just for determining FiO2. Okay. So we're going to start practicing and our ABGs. Do you need a break or are we okay? Let's take a break. 10 minutes?
Yeah.
Okay, let's take a 10-minute break. We're going to come back and get into some gases. Okay, ready, friends? All right, let's do some ABGs. So, our patient has, oh, I want to switch over to, because I can write on my thing like I did during my.
You need to lay.
Yeah. What we just heard. Oh, really? I'm afraid about it. Some real feel over here. What's the password, TT? She never told me what's the password. Every hallway. Keep it on the way.
Who paid the bills here?
Agent. She got a record for active girlfriend. Oh, and was she against where's the invoice? No, she only wrestles. She drives to just okay. Once around. But she was so mental space is like this, right? This once again, that feeling in wonder, please. Where's what take my
Oh, it's I didn't know it was gonna say like that.
day on the bleachers
What?
with my son. I just wanted to yesterday. I just
See, I'm getting no lunch.
I'm doing it on my phone desk. Oh, no, but I'm right there.
here's my problem.
Get to it.
So what's that?
Oh, you like you're doing on your computer.
Okay.
Yeah, because on the computer it show it's kind of a lot, kind of overwhelming.
Okay.
But if you really, need the information, it's all there.
Okay.
So what
She is 60.
that's why like I opened it and then I got off of it.
Probably use options.
But
She
I didn't really look at it. So I need to fill out this paper for these ICU medications.
well known the native bands. Which you the visual major. It was sweet for you way. So that's like bands. Yeah, it was. Like the mermaid.
Do you guys have it all in front of you on your screens? Ring
Yes.
Central.
You got Ring Central now, but I'll put it in.
Okay, because I'm gonna share it from this screen, so it's not gonna be up here. It'll be back there, but it won't be up here.
We're not doing this, right? We're just doing it in the morning.
No, we're just doing the PowerPoint.
Okay.
I mean,
Oh, girl. Dinner. It's too many damn computers. I look at this. Since I knew it. Just beginning to get.
oh,
She's like,
It's gonna make my day better.
right, yeah, just one day. Is it?
So look on my phone. And that's like there's on there, ain't on there no more. They put tuition on there.
You want it, so I know it's like.
They put one on today?
Like it said that I had a space on there. But then they just put the tuition in there.
Oh, so they took it out.
Yeah.
Yeah, our
All
people.
of it.
So you're probably gonna get it.
And you guys-
Yeah, because that's what they told me.
But if that's the case, then they can give me two because they didn't give me the one from November for
I think
the
they're gonna combine it into one. That's what she told me.
Okay.
She's like, well, you have 2 more going in February. She's like, we're probably going to discuss the whole thing in February. So I was like,
Oh,
yeah.
okay, well, that's good then.
Yeah.
So,
That's why I was like, you know what? I need to complain to her and use it.
yeah. I gotta get my passport. I gotta work.
Okay.
Next week, I'm gonna work next week. Sorry.
Are we ready?
Yeah.
Oh.
Work. What we're gonna do
That one
last time.
beer, shit.
Yeah, those be great. Yeah, I think
We took it. I took a nap and I was
Okay.
get out of here.
yeah, I'm gonna test like.
Oh, stop it. Stop it.
Hold on a second.
Oh my God. It had.
Take a break. Hey, girl. When we're doing control space, we're gonna start playing beats too.
Yes.
She might get brave me. I'm here. Sit here in her bed, but we really need to go to the gym. It's not really hot.
Okay. Figure because we're too busy right now.
Yeah.
I guess I should keep it this way. Here. It's my first time doing this. Okay. So. How do I? Listen, I have had this surface with this stupid little pen for like 2 years, and I just started using the pen, so forgive me because I don't know exactly how to use the damn thing. I want to write. No, it's just me trying to figure out how to do stuff. Maybe I should.
Save it and open it up.
Oh, gosh darn. Get me out of here.
You guys need like the chain tested.
Oh, from the NCBs, whatever, they email me.
It's for real.
Changes from this.
Am I stupid?
And then critical questions. Partial credit for like for questions. Or
It's supposed to be. See if that's now.
So
Please say that.
maybe I need to do it as a PDF.
yeah, that's what I mean when I said save it.
They changed it, the word, substance abuse to substance
I'm really sorry, guys. I just want to do this in a good way. Okay, so now it's gonna let me write. Okay, all righty. Okie dokie. So we have a pH of 7.55. Where do I fall? Okay. We have a CO2 of 28.9.
Acidic.
Alkaline.
Oh, yeah, alkaline.
Okay. We have a bicarb of 27.6.
Alkaline.
They're all over here.
Oh heavens.
Okay. Our FiO2 is at 30%, which means that is the percent of oxygen our patient is receiving. What is the percentage of oxygen of room air?
21.
20.
21. 21. Our percentage of room air is 21. Okay, so the FiO2 of the world right now on room air is 21%. Okay. So our patient in this situation has an FiO2 of 30%. So they are requiring 9% higher than room air. Okay. In order to do a PF ratio, you have to change that 30% to a decimal. Okay. So it's the PaO2 divided by the FiO2. So for this, our PO2 is 98.2. Our FiO2 is 30%. So it's going to be 98.2 divided by 0.30. Okay. What?
It's 327.10
So 98.2 divided by 0 equal to 327.3333333333.
I'm still talking. So that would be a bit.
So when it comes to a PF ratio, the tenths don't really matter. Okay, we're rounding to the whole number. All right. So 327.3 continuing is going to be 327. Okay. If it was 327.8, it would be 328. Okay. So we are rounding to the whole nearest number, the nearest whole number. Okay. Does that make sense? Okay. So PF ratio interpretation. A ratio greater than 400 is great. That is adequate oxygenation. If right now I am sitting at 99% SpO2, my PaO2 is 99, and I divide that by 0.21, my PF ratio is 471.
So you get good.
So that means that I am adequately oxygenating right here on room air. Okay. If my PF ratio is between 300 and 400, I have hypoxia. I'm having some hypoxia here. Okay. If my PF ratio is between 200 and 300, I have started getting into ARDS. ARDS has begun. Okay. And my mortality rate has gone sky high. If my PF ratio is less than 200, then I am in a critical respiratory failure. I have gone on to severe ARDS. And my mortality rate has increased to almost 50%, 45%. Okay. So if my patient has given me a PF ratio of 327, what is my patient falling under? So they are hypoxic. What do we do?
Increase that by.
Yes. Increase the FiO2. Oh, it says it right there. I was about to be so proud of you.
The respiratory therapist showed me this on the ventilator.
Oh, well, that's good. Well, I was really excited because I thought you got there on your own. I was like, yes. Okay, so we have an FiO2 of 30%. We can go all the way up to 100. We got a lot of room to grow when it comes to FiO2. Okay. So if our patient's hypoxemic with a PF ratio of 327, all I have to do is go up on my FiO2. So I go up to 40% and then do another ABG in an hour or so. Okay, hour to 2 hours to reevaluate. All right. So,
Here.
Mr. Martin is a 55-year-old man who presents to his PCP on a Tuesday with complaints of a productive cough for 3 days with fever, chills, fatigue, beginning in the last 24 hours. This clinic has capabilities for X-ray, rapid lab results, and simple IV infusions. His PCP hears coarse rhonchi in Mr. Martin's lungs and decides to take a chest X-ray. The X-ray shows right lower lobe infiltrates. What does that mean? Fluid. So there's fluid in his right lower lobe. His rapid flu swab is negative. Mr. Martin's vital signs were as follows. We have a blood pressure of 122/73, heart rate of 102, respiratory rate is 26, our temperature is 38.6, SpO2 is 94% on room air, and he weighs 105 kilograms. Mr. Martin is diagnosed with pneumonia and sent home on azithromycin. 2 days later, on Thursday, Mr. Martin still has the cough, fever, chills, and fatigue, and is now having body aches on and off and is short of breath intermittently. He calls his PCP concerned that the antibiotics are not working. His PCP agrees and changes his antibiotic to amoxicillin. On Friday, Mr. Martin's wife calls his PCP again because he is struggling to even get out of bed and is very fatigued and feverish. She reports a fever of 102.9. The PCP tells him to come into the clinic. He arrives at the clinic 20 minutes later. I got some red flags here. Okay. I see some red flags. First of all, bro's 55. Okay. He's not young, but he's not old. And on presentation, he's already 94% on room air and tachypnic. Okay. So kind of borderline needing supplemental oxygen, even if it's like 1 to 2 liters. Okay. And they gave him azithromycin and packed his bags and sent him on his way.
They said not breathing.
I don't know if they did labs, and I don't know. I'm not on my next slide yet. But did they do labs? What's going on? Okay. We know he has pneumonia. We know he has a productive cough. He already has a fever, chills, fatigued. Okay. Then he calls back and he says, listen, I am getting really sick here. What should the PCP have done? Have him come in. If he was 94% on room air, how many days ago?
But the PCP did tell him to come in.
No. I'm talking about the middle part.
3 days before he changed it.
So right before he changed it, Mr. Martin is diagnosed with pneumonia and sent home on azithromycin. 2 days later, he calls.
And they switched him to amoxicillin.
Instead of his PCP saying, hey, I think you should come in so I can take a look at you and see what's going on, get some vital signs, see a pulse ox, he just says, let's throw some amoxicillin at it and see what happens. Okay? So the reevaluation has not occurred. He's just saying, let's take some other drugs. All right? Then on Friday, so what day is this? Tuesday. So we start on a Tuesday, Wednesday, Thursday, Friday. 4 days, our friend Mr. Martin is now septic. Okay? So he is very febrile. He cannot even get out of bed. Guess what is happening? Bet you his lactic acid's through the roof. Bet you. Okay. So he arrives 20 minutes later. So on the right side is a very normal looking chest x-ray, which by the way, that looks like a person that has breasts. This is a female chest x-ray. I did not make this.
Let's see.
We're not
Mr.
judging.
Martin has some things
Mr. Martin
going
has
on.
gynecomastia, okay? And on the left is it's not a complete whiteout, but this is definitely what we would call bilateral infiltrates. We have fluid accumulation in both lungs seen on both sides. We have hazy white presentation. It's not a complete whiteout, but it don't look good. Okay? So, what nursing assessment should we be doing at this time for Mr. Martin? He just walked into the ER.
Assessing vitals,
Oxygen.
So we need to assess his vital signs.
Auscultate the lungs.
Auscultate his lungs. Okay. Respirations with the vital signs, sure. Check for pain. Yeah.
he's fatigued, dark skin, temperature,
Also say his heart.
like diaphragmatic cleaving.
Listen to his heart. Listen to his
Start an
lungs.
IV.
Look and see if we have any going on. Start an IV. So we haven't talked about septic shock yet. We're going to talk about that next week. But one of the first steps of sepsis recognition and treatment is rehydration. Because what happens when you have a high fever? So what happens to water in heat? It evaporates. So the same thing happens in your body. When your body gets really hot, it rapidly uses up the fluid. That's why when you're sick, they say push fluids, because you need more fluid to deal with the heat. Okay. So he's most likely pretty dehydrated. And we're going to need an IV with some fluids. Okay. Blood work. What else can you do with the blood work? A gas, an ABG. What about cultures?
Oh, yeah.
Because our patient, we're septic now. We're at the point of sepsis. Okay. So what happens after sepsis? Septicemia, which means that that infection has now gone from its main area to the blood.
Right.
Okay. Which is when you have positive blood cultures. So, upon further assessment, Mr. Martin has bronchi throughout his lung fields with occasional expiratory wheezes. He appears pale and is lethargic. His skin is tenting, so he's dehydrated on his sternum, and his nail beds are pale. His vital signs are as follows. Blood pressure is 108/66, heart rate is 116, respiratory rate is 30, temperature 38.8, SpO2 is 92% on room air. First of all, what is this temperature in Fahrenheit? 101.84?
Yeah.
Okay. I thought it was higher.
Remember the.
I thought it was gonna be higher. Our oxygenation is lower on room air. He's tachycardic. His blood pressure is a little lower. It's not in a dangerous place, but it's a little lower than what it was on our first slide.
It's crazy.
Okay. So what diagnostic tests would you anticipate?
ABG.
An ABG,
Electrolytes.
blood cultures, electrolytes, a CMP or BMP. What comes with the metabolic panel?
Within NSD.
Yeah, other than electrolytes.
Which I can.
Oh, your kidney.
Kidney function. What happens to your creatinine when you're dehydrated?
It goes up.
It goes up.
Okay.
And what happens with prolonged dehydration in AKI? An acute kidney injury. Okay. So we're getting complex here. We're involving multiple organ systems at this point. Okay. A lactic acid. Huh? Yeah. Okay. What else?
If we did cultures, would that also wrap up to see what kind of antibiotic it is, or would we do broad spectrum?
So she said if we do cultures, would that give us an answer on what antibiotics we were getting?
Yeah.
So,
That's what you-
what is the difference between a culture and sensitivity?
Oh, the sensitivity is.
Ah, so just getting a blood specimen is not going to tell you anything about antibiotics.
It just would take
You
more
need
than-
a C and S, culture and sensitivity. So your blood culture can come back positive, but that doesn't that's going to give you the organism, but that doesn't necessarily mean it's going to give you what you're most sensitive to when we're talking about antibiotics. Okay.
So sometimes would we do it in this case if he's suspecting sepsis? And
So in this case, this patient is primarily from the lungs, right? So if they really wanted to, they could do a bronchoscopy, get a
Okay.
culture from the bronch, and then do a CNS on the bronchoscopy. They could. But also, when you think about it, when you get that specimen back and you find out what kind of organism it is, that also helps you choose your antibiotic. Okay, good question.
Those take a couple of days, don't they, though?
They sure do. That's why we usually start off with a broad spectrum antibiotic to try to cover our bases until we can figure out the originating organism and if we need to change it or sometimes stack them on each other, have multiple IV antibiotics at this point. That's very possible. So what would be some priority interventions for Mr. Martin at this time? We need some supplemental oxygen, for sure.
Can you scroll back up a little bit so I can forget those?
We need some fluid rehydration, for sure.
We need to give them antipyretics.
We need to bring down the fever. Antipyretics. We need some Tylenol,
And hydration.
probably not NSAIDs, because we need to protect the kidney function and protect our stomachs. And what else did you
We
say?
need to get respiratory.
Hydration.
We need to get.
And when we monitor eyes and nose as well?
Absolutely monitoring eyes and nose, 100% yes. Okay.
I said fall precaution because if he's hypoxic, short of breath, he can fall.
Totally fall precautions. What if he goes into acute respiratory failure and then he has hypercapnia and we haven't even gotten a blood gas yet? I have no idea what his CO2 is. He could totally get confused. Okay. Mr. Martin's PCP believes he is suffering from dehydration related to his fever and orders 1 liter of normal saline to be infused in the clinic before sending Mr. Martin home. The nurse.
Mr. Martin needs a new PCP.
Mr. Martin damn sure needs a new PCP.
He needs to
Nurse
file a
starts
complaint with the board.
peripheral. Huh?
He needs to file a complaint with the board.
Amen. She starts a peripheral IV, initiates the fluid bolus, which takes 1 hour to infuse. What evaluation information would you, as the nurse, want to obtain following the infusion of these IV fluids?
Patient reaction.
How about, she said patient reaction. I'm going to replace that with patient responsiveness
There we go.
or implementation response. Okay.
Is that asking the patient, do they understand what's going on?
So really, I mean, so it's saying you are the nurse. This is your situation. You want to obtain information following the infusion. So how are you evaluating how your patient responded to the fluids?
Like if their respirations came down.
Oh, Scanner says,
How's their vital signs? Are they still tenting? His skin was tenting over his sternum. And by the way, I didn't realize we were still at the PCP office. He's not even at the hospital yet. We're still at the PCP office. So we didn't get no blood cultures. We didn't get no bronchoscopy. We don't even have supplemental oxygen at this point.
Nope.
He's just giving this man fluids. Okay.
recheck his fingernails,
I-
the tail.
Alert and oriented. Signs of cyanosis, tissue perfusion.
Hopefully he the one doing the talking about it. Like,
Okay.
Oh, yeah.
I mean, honest, this gets so much worse, by the way. Like, so Mr. Martin's infusion completes after hours on Friday. After hours on Friday from the PCP office. The medical assistant removes his IV, tells him he can go home, and to call the on-call team if he has any concerns. By the way, when you start taking an antibiotic, how soon do you start usually feeling better?
24 to 48 hours.
24 to 48 hours. If you're not feeling a little bit better after that 24-hour mark when it's a bacterial infection and you're symptomatically getting worse, and then they started you on a new one and you're still symptomatically getting worse, we have a problem. We have a very big problem. Okay? So, Mr. Martin returns home and tells his wife he doesn't really feel any better. For the next 2 days, over the weekend, Mr. Martin continues to be more and more fatigued. He already couldn't get out of bed on Friday. His wife finally, this poor wife, finally calls the PCP on Sunday, who says to bring him in first thing the next morning. Are you so for real right now, PCP? On Monday morning, Mr. Martin arrives at his PCP, who can immediately tell he has gotten much worse. He repeats a chest x-ray to find diffuse bilateral pulmonary infiltrates. Mr. Martin is sent straight to the emergency department. Bro, you are
That
3
should have
days.
happened Friday.
You are 3 days too late. He should have gone to the ER on Friday. Also, he should have actually, I take that back. He should have gone to the ER probably on Thursday when his symptoms were getting worse.
So the ER can send him back? Because that's exactly what was gonna happen. The ER was gonna send him back
Well,
home.
if the ER would have sent him home on Thursday, they would have gotten labs. They would have given him fluids. They would have treated him probably more appropriately with a better antibiotic than slapping some amoxicillin on it. Okay. So what step of the nursing process was skipped?
All of them.
So Todd, we're talking
Reevaluation
about
after
here.
the liter of fluids.
Say it again, Kelsey.
Reevaluation after the liter of fluids before he got sent home on Friday.
So I agree and disagree. Reevaluation, yes. After the change in antibiotics, there was no, really before the change in antibiotics, there was no reevaluation of the patient.
After the azithromycin medicine.
That patient should have come into the office and been seen physically by that PCP to be reevaluated before a change in antibiotics had occurred. On Thursday. Or was that Wednesday? I'm sorry. Was that Thursday?
Thursday.
So, Mr. Martin arrives in the ED where providers confirm the diagnosis of bilateral pneumonia. Remember, this started on Monday in the right lower lobe. Localized. And now we are bilateral diffuse pneumonia. Mr. Martin's SpO2 is 88%, so he's placed on 4 liters nasal cannula, which is 36% FiO2. The provider writes the following orders, which are implemented by the nurse. Keep oxygen saturation above 92%. Repeat the chest x-ray in 4 hours. He wants an ABG, a CBC, a BMP, and blood cultures. Insert 2 peripheral IVs. Give 1 liter normal saline IV bolus now, and give albuterol nebulizer 2.5 milligrams. His blood gas is pH is 7.3. CO2 is 58. Our SaO2 is 96. He's on 4 liters of oxygen, and bicarb is 26. So, where is my pH?
He's in respiratory acid.
Where is my CO2? Okay. And where's my bicarb?
Normal. Oh, yes.
Okay. So, if you do not have a PaO2, use the SaO2. Yes. Okay. So we need to convert the 36% to 0.36. So 96 divided by 0.36 equals what?
267.
267. If
And
you're
6.
rounding at the 10th place, yes.
You know, doing choose.
So first of all, is this compensated, uncompensated, or partially compensated?
Uncompensated.
So,
Oh wait, no, it's partially because we got one trying to make up for the other. Uncompensated.
uncompensated because the pH isn't normal. No, the pH isn't normal.
Uncompensated.
Compensated.
So if the pH is normal and the other two are not, that is full compensation. If the pH is abnormal and one of them is normal, that is uncompensated. Okay, because the compensation has not occurred. If the patient was compensating, the bicarb would be higher trying to compensate for the acidosis. Partial compensation is when the whole middle is empty. Nothing is normal. Okay, so this is respiratory acidosis. Uncompensated respiratory acidosis. Ooh, I just lost you for a second. Can you guys hear me? No? Yeah?
Yeah.
Okay. So going back to our chart,
He's in orange. Yeah.
what was it? 267?
Oh. Yes.
So, which by the way, I need you to know this chart. Put a star next to it. Okay. Our patient has now gone into acute respiratory distress syndrome with a mortality rate of 27%. But we only are at an FiO2 of 36%. We have a ways to go. We can improve. We got this. Hopefully, maybe. Maybe. Okay. No. Okay. Well, we already did this, so this is 267. And we have reached ARDS. Remember, our first phase was what?
So adequate, then hypoxia, then words, turbo.
Hypoxia.
What is our first phase of ARDS?
Oh, down.
XU. Oh, XU.
Exudative.
Exudative? Okay. So we're on day 7, right? He came in on Monday. Now it's Monday again. We're on day 7. We're in our exudative phase. Okay.
Mhm.
So what's happening? We have increased pulmonary edema. We have refractory hypoxemia. What else do we have? Fibrous tissue is starting to develop. We don't like that. Our alveoli are not happy. They are collapsing. Okay. Mr. Martin's condition continues to deteriorate. He's now placed on BiPAP and sent to the ICU. The next day, he is still struggling to oxygenate, and the family agrees to intubate him and place him on a mechanical ventilator. He is placed on assist control. We also call this AC, assist control. FiO2 of 100%. Tidal volume is 440 and a PEEP of 5. Now let's talk about what this means, okay? A tidal volume is the amount of air that you inhale at one time. When you are on a mechanical ventilator, it will give you a set amount of tidal volume every time. So if I set that volume at 440, it is going to deliver 440. Okay? Every time you inhale right now in your seat, you are breathing in a tidal volume. Whether it's you're in the middle of talking and it's 200, take a big breath and it's 900. It's always changing.
It's not both inhalation, so just
No, it's only inhalation. Your tidal volume is the amount of volume inhaled at one time. Okay. A PEEP. PEEP stands for positive end expiratory pressure. So what does that mean?
Coming out.
That means if I'm just forcing air into you, what is going to keep everything from collapsing when I force the air out? Nothing. Without PEEP. PEEP is what keeps your alveoli open and stopping them from the entire lung collapsing on itself when the ventilator exhales for you. Yeah, it's plugged in right here. We're talking about PEEP. So, and the alveoli collapse. So, if we didn't have PEEP, when the tidal volume in, your lungs are going to fill up like balloons. And then when it forces the air out, the lungs would collapse. You never want your lungs to collapse. Collapse, even when you exhale completely, your lungs don't ever collapse on themselves. So the PEEP is what keeps the lungs open and the alveoli open for oxygenation. Okay. Now, PEEP can be very dangerous. A PEEP of 5 is normal, that's standard. You don't ever really want to go over a PEEP of 14. So when you're talking about an inhaled amount, you're talking about a pressure. There's a force that has to occur that forces that air in. There's also a force that has to be on the other side when that air comes out. So you have these two forces fighting against each other. When you have a patient that is in severe ARDS and you have a lack of oxygen and CO2 exchange, the alveoli cannot stay open and ready and oxygenating between the capillaries, then and you have refractory hypoxemia, The only option you have when your FiO2 is at 100%, the only option you have at this point is to increase your PEEP. The higher the PEEP, the higher the pressure. Your pressure can only be so high until you pop the balloon. We don't want to pop the balloon. Popping the balloon is bad. Okay? So, he's maxed on FiO2. He has a PEEP of 5, which is standard. We have a tidal volume of 440, which is it's not that bad. 500 is a very normal amount for an adult. Okay. After 1 hour, a blood gas is drawn with the following results. We have a pH of 7.25. What is that?
Acidic.
We have a PO2 of 90. CO2 is 52. So where's my, thank you. And our bicarb is 28. So we finally have some compensation a little bit. Something's starting to work somewhere. Okay. So we have now reached what type of compensation?
Partial.
Okay. What is my PF ratio?
I'm sorry, Michelle, so you was breaking up a little bit. What was your question?
What is your PF ratio? What is 90 divided by 1?
90.
Thank you. My PF ratio is 90. That's bad. That's really bad. So what physiologically is going on with Mr. Martin at this time? Look at the chart. Look at the chart on ARDS.
The fibrous stage.
What is my key hallmark sign of ARDS? Refractory hypoxemia. We have 100% FiO2, and he is still not oxygenating adequately, as evidenced by SpO2 and our PF ratio. So our patient is not adequately oxygenating despite providing a maximum amount of oxygenation. Mr. Martin is in the ICU for 14 days. He has multiple bronchoscopies to attempt to clear the fluid from his lungs. He was continued on high-dose IV antibiotics after his blood cultures revealed strep A pneumonia. His PEEP is progressively increased until it is at the max of 14. Remember, I told you, we don't go over that. He is placed on lung protective ventilator settings, which is APRV. We will get into those settings to prevent barotrauma and promote opening of the alveoli. Remember, we have things called baroreceptors. Those baroreceptors are responsible for constriction and vasodilation. So when you have trauma to those receptors, we are not dilating or constricting adequately. Okay.
I just want to clarify, the peak, it can exceed 14.
Correct. PEEP should never go over 14. He remained in severe ARDS despite all interventions. He was too unstable to take to the OR for a trach and ended up going into cardiogenic shock, which we will discuss next week. Despite all interventions, Mr. Martin passed away with his family by his side on the 4th day in the ICU. It's very sad, and it happens all the time. So what would you have done differently for Mr. Martin? When and why?
When he was feeling worse, I would have made sure he went to the emergency room.
So we already talked about, we missed that re-evaluation when he did not get better with the first round of antibiotics. That was the very first missed mark. Okay. And then he came in, or he didn't come in, he got called in new antibiotics. They switched him to amoxicillin. He then got progressively worse. The patient came to the PCP's office and got a liter bolus. The patient was never put on supplemental oxygen, despite at that point being at 92%. He was severely dehydrated. When your skin is tenting over your sternum, you are severely dehydrated. 1 liter bolus isn't going to do nothing for you. Okay. We didn't get any vital signs after the bolus. This was a Friday after hours with evaluation from the PCP, only from the nurse who was giving the bolus, and then the medical assistant removed the IV and sent him home. There was no reevaluation again after that bolus. Then his poor wife waited till Sunday to call again to say he was getting even worse. And then still Monday morning, still was told to wait overnight, which, by the way, you are going to learn in your career very quickly that one night can go downhill really, really fast. It doesn't take a lot of time, especially when your patient is severely compromised and very ill. So now we've missed a mark again when she called on Sunday and said he's getting worse. And they didn't send him to the ER right then and there and made him wait overnight to go to the PCP's office again before going to the ER. There's a lot of missed opportunities here. A lot. So, what is his cause of ARDS? Because remember, it's secondary. Pneumonia. Strep A pneumonia was his primary cause. What are the main aspects of patient education for ARDS? For patients or family? Okay, you could definitely educate your patient or their family about how ARDS is secondary, for sure.
Treating the underlying.
Treating the underlying condition, oxygenation.
For patient education. So I guess I'm kind of
Expected outcomes.
motivation.
Expected outcomes.
What about early symptoms?
Early symptoms. When to go to the ER and when to wait. Right? Because poor Mrs. Martin, she didn't know.
She did the best.
She didn't want her husband to die. She did the best she could with what she had.
What she knew.
And that is a problem when you think about the US and our medical system. Our patients are severely medically uneducated. You're going to talk to your patients about their pills and they're going to be like, oh, the little red one. What's that for? I don't know. I take it because my doctor told me to. Okay. they don't know these big words. A lot of people, your patients are not going to understand the pathophysiology of their disease. And it is because of the lack of education to our patient population. Not only, and don't even get me started on the education, we're through the whole country. K through 12. Okay. So what differentiates ARDS from acute respiratory failure?
That refractory,
The fluid buildup in the lungs.
The hardening.
Refractory hypoxemia is definitely a difference because that is the hallmark sign of ARDS.
That fibrous.
Pulmonary edema can happen in both. When you're talking about the tissue changes that occur in ARDS, that tissue trauma, the lung trauma, that doesn't happen in acute respiratory failure.
so the stiffness hurts.
That stiffness and fibrous tissue and that permanent damage occurs in ARDS. Also, when you're thinking about acute respiratory failure, you also have hypercapnia. Okay, that can happen in both. You can see an increase in CO2 when you're in ARDS, right? But that's the hypoxemia and hypercapnia in that acute phase, that acute respiratory failure is significant. When we're talking about ARDS, we're talking about how many days? 21, or I'm sorry, what was 30 days? 30 total days? If you even make it that far, if you live that long. Okay. So differentiating ARDS from acute respiratory failure is the injury, the permanent injury to the lungs, and refractory hypoxemia. So we are halfway through our slides. 33 out of 60. I think a lot of we have another case study at the end, I believe. Yeah,
I need to scroll like way up back to our case study.
way up. Which part of the case study?
Probably the second part, the first time we said with refractory hypoxemia. Yeah, right in there.
No, I didn't.
Oh, it was summer. We said it twice, and I'm just kind of confused at how we knew that he was having refractory hypoxemia before we even
The
increased
first
his
time?
oxygen. Yeah. I mean, before we even put him on oxygen, like doesn't that we have to put him on oxygen to know that it's not getting better before we can say it's refractory hypoxemia?
So she's asking about refractory hypoxemia and how did we know that? So on this slide, he's 88% on room air, so he is placed on 4 liters nasal cannula. And then the blood gases, his O2 is 96%. So I guess it was a little impulsive to say that on that slide that it was refractory, because really, if you think about it, on this slide right here, he is responding to the 4 liters because he went from 88% on room air to 96%.
Mhm.
So I guess it was a little too early for me to say that. Yeah.
I just got a little it's right there.
No, that's okay. That's a good question.
RH.
Oh, there it is. Oh, I think I was looking more at the PF ratio.
Okay.
But you're right though, because I want to be clear when we talk about refractory hypoxemia. It is the patient is receiving a high amount of oxygen and not responding and is still hypoxic. So still having hypoxia, even though they are adequately oxygenated. That is the definition. So I jumped the gun a little bit. Good question. Because even here on this slide, our PaO2, which let's just say PaO2 is 90, which is a little low. Our oxygen saturation is 99%, but a PaO2 and an oxygen saturation, they're not really interchangeable.
Very high.
No, they're not interchangeable. You can use the SpO2 if you don't have it on the gas, like a PaO2. You can use the SpO2. But if you have a PaO2, you always use that over a pulse ox.
Okay.
Okay. So even here, you're starting to see the refractory hypoxemia here because the PaO2 is 90. So you're starting to see a little dip in oxygenation. And then it just gets significantly worse. Poor guy. Questions on ARDS and acute respiratory failure?
So the difference between this.
The difference between the two, you can have hypercapnia with ARDS. You can have hypercapnia and hypoxemia with ARDS. Because if your patient has respiratory acidosis with ARDS, you're going to see that hypercapnia because it's caused by the retention of the CO2. But your differentiation is with ARDS, you have injury to the tissue, that severe inflammation and pulmonary edema with fibrosis. Acute respiratory failure, you don't have that. So think about it in a reversible way. Acute respiratory failure is reversible. ARDS can be, if it goes past that proliferative phase where it said, this point people get better, or this point we don't get better, then we are talking about permanent irreversible damage. Fibrosis will never go away in the lungs. Okay, we have 1/2 hour left.
The PowerPoint thing needs to go.
Huh?
Move your mouse and switch.
Oh. Oh, my legs.
Sit for a second.
Oh, I gotta stand up for a second. My legs are falling asleep.
I know I can move it.
Why don't we all stand up and just shake it out a little bit, because we don't have a lot of time to take like an actual break. So Wednesday we're here 9:30 to, I wrote it down.
Oh, so 30.
Is it 2:30? 3:30. So it's a long day. So we have plenty of time on Wednesday. Don't say those. Don't say that word.
What's that?
Don't say the EARLY word.
Yeah. Day1.
Oh, it only has 4 more slides? Okay, we'll do 4 more slides and then it says end of day 1.
Oh yeah, I see it.
Think? I don't know. I talk a lot. I'll just leave you with one thing. I'll leave you with one thing. Pulmonary artery hypertension. Somebody last term asked me a question. They said, I don't understand how a patient can have pulmonary artery hypertension without regular hypertension. Makes sense. Okay.
So it's
Maybe I think of it
of the
like-
artery.
So when we're talking about pulmonary hypertension, it is only affecting the pulmonary arteries.
Right.
That's what I thought,
Okay.
but the name kind of says it, like it's.
Exactly.
But when one person asks, there's going to be somebody else,
Yes.
Yeah,
right? So when we think about blood pressure,
I didn't think I was right either, but I'm just saying.
well,
this
you
is
sure were. When we think about blood pressure throughout the body, we have a lot of different reasons for increased blood pressure. Okay. Do we have an issue with the renin angiotensin aldosterone system? Is there something wrong there?
It could be.
Okay. Is there something wrong with the baroreceptors within the arteries? Okay. Is it a cardiac condition? There are multiple reasons for regular old hypertension. Okay. But pulmonary hypertension is just specifically within the lungs. So this is increased blood pressure in the pulmonary circulation. So you have a normal mean pulmonary pressure that is between 12 and 25. And it can only be measured through a right heart cath. That is the only way you can get a mean pulmonary pressure.
Okay, I don't see.
There's no other way to get this.
I need to. I don't see it.
Oh, yeah, it's right under mean pulmonary pressure.
And this is an exact number. If you wanted to get an estimate, you could have an estimate on an echo. But if you wanted an exact number, you would have to do it through a right-sided heart cath. Not a left-sided heart cath, a right-sided heart cath.
I don't mean to cut you off. They're saying this on the ballot.
It is on the PowerPoint. Did you
It is.
print the one without the filled-in slides?
Really see it.
Oh, it's just really small.
Okay, let's see.
So there are two types of pulmonary hypertension. The primary, this is super sad. It's very very rare. It usually affects women between 20 and 40 years old, and it is usually fatal within 5 years of diagnosis.
Before you go too far, what is the abbreviation?
PAH.
Okay.
And the primary idiopathic, it's called idiopathic because we don't know. It's unknown. We don't know why it happens.
So if it's fatal, does like the pulmonary artery just get smaller, smaller, and smaller or something? Or
Well, so
narrow.
why is it fatal is because it puts so much stress on the heart.
Okay.
And remember your preload and afterload. So when we talked about preload and afterload, we talked about it within the left ventricle and the aorta. Okay. But there's still pressure on the right side. So we can think about preload and afterload on the right side also, because the right ventricle has to pump through the pulmonic valve into the pulmonary vein, or I'm sorry, the pulmonary artery to go into the lungs. Okay. So wherever that valve is, when you're going into another circulation, there's going to be pressure on that other side. So if you have narrowing within that pulmonary artery, the vascular resistance, that arterial resistance within that pulmonary artery, your afterload in that pulmonary artery is going to be so high, which is going to cause right ventricular hypertrophy, which is what we see on this picture where it says enlarged right ventricle. That is called right ventricular hypertrophy, which is then going to cause right-sided heart failure. So why is it fatal within 5 years? Because number one, it's very rare, which means that it's probably misdiagnosed and caught late. And then at this point, Remember, these women are between 20 and 40 years old. What happens when you're young?
You don't care.
You compensate really well.
You said you don't care.
And a lot of people don't care. Maybe they don't have insurance. I don't know. Right? You're 20 years old. You want me to do what? Yeah, I'll go when I'm 35. I'll go to my PCP yearly when I'm old. Right? So this is a 20 to 40-year-old woman living her life. Okay? She's got symptoms. She doesn't know what they are. She goes in. Maybe her right-sided heart failure is already progressed. She already has right-sided right ventricular hypertrophy.
Look at how they spell berry.
Huh?
Look at how they spell berry.
Oh.
B-R-Y.
Oh yeah, that wasn't me. So that right-sided ventricular heart failure is what ends up being fatal in the end, because the heart just can't compensate at this point. So then secondary results from existing cardiac or pulmonary artery constriction diseases, and the prognosis varies. So a lot of the times your PAH is controlled with medication. And they're able to lower that pressure within the pulmonary artery, and the patient, they may have some difficulties. Maybe they get short of breath walking up the stairs or during activity or whatever, but it's not killing them right now. It's controlled. The secondary type of PAH is not nearly as fatal as the primary.
Thinking I'm doing something.
This is the last thing. So our symptoms when our patient is experiencing PAH is going to be shortness of breath, dyspnea, syncope, chest pain, loss of appetite, JVD, ascites, peripheral edema. These are signs of right-sided heart failure. Okay. Your treatment is going to be anticoagulants, thrombolysis if you have a clot, surgery, a pulmonary thromboendarterectomy, and by the way, this treatment is very geared toward clots and clot prevention. Your diagnosis, they can see the right ventricular hypertrophy on a chest x-ray, just like we can see the left ventricular hypertrophy on a chest x-ray. An echo is going to give you that estimated mean pulmonary pressure. An EKG is obviously going to give you your heart rhythm. The right heart cath is going to give you an exact mean pulmonary pressure and visualization. It's also going to allow them to see the narrowing that's occurring. And then chest fusion scan. This is also called a VQ scan. There's a term that I'm going to talk about on Wednesday called VQ, or ventilation perfusion mismatch. And this scan is diagnostic specifically with PEs, which is why we're going to talk about it on Wednesday. But it can show the mismatch in ventilation, which again, we will talk about on Wednesday. And then with nursing interventions, there's really only so much we can do with prevention for PAH, especially if it's primary. You're not really preventing anything. But for secondary, prevention is going to be knowing that those initial diseases can result in PAH and trying to control those symptoms before they lead to PAH. Of course, oxygenation, emotional, and psychosocial support. That is where I shall leave with. Clock days are long. Long days. Because we should like 5 hours on Monday. So instead of 5 hours on Monday, it's time for to over yeah. Much love and respect for the man. He screwed me up this month.
So do you one day?
I was gonna say, I just like we didn't realize that it wasn't Tuesday. We made the whole schedule with everybody here on that Monday. And then all of a sudden it was like it's a federal holiday. Yes, ma'am.
Sure.
But some kind of yeah. Questions? I'm gonna do the analysis very shortly and have grades updated soon, okay?
I have a quick question.
Yeah, go ahead.
For exam reviews, are you doing like one-on-ones or are you doing like a group review?
So for exam reviews, if you get they used to be SAPs, they're now called CPTs. I know. If you get a CPT, then we really should meet individually. If you do not get one, I like to hold exam reviews at some point as a group because there's just too many of you to do it individually. If you really want to do it individually, reach out to me and there's a link to make an appointment with me. In my like where it says like meet your instructor or whatever and it says how to contact me, that link is where you make an appointment with me. But wait until you get if you get a CPT, and then I will send the link in that for you to schedule.
Okay, it didn't matter whether a group or together. I just wanted to review. I didn't do bad, but I just wanted to review.
Yeah, no, I definitely want to do an exam review for sure.
And the last question is this slide that we're on now, like the slides that you're doing for this week, is these the slides for the exam next week?
Yes, ma'am.
Okay, that's it. Thank you.
Yep. Anybody else? Questions? Okay. All right. I'll see you.